Welcome to this explainer. Today, we're diving into a topic that's frankly surrounded by a whole lot of noise and misconception: schizophrenia spectrum disorders. For a lot of people, their understanding of this is fueled way more by dramatic pop culture than by actual grounded science. So we're going to change that. We're going to take a really close look at the neurobiology, the symptoms, and most importantly, the very real human experience behind these conditions.
But before we get into the heavy neuroscience, let's test our baseline. True or false? Schizophrenia is a rare illness. Now, if you guessed true, you are definitely not alone, but it's actually false. It is far more common than most people think. In fact, psychotic-like phenomena exist on a continuum across roughly 10% of the general public.
Section 1. Fracturing reality. Symptoms explained. To truly grasp this condition, we have to start by understanding the intense, profound despair that accompanies it. The renowned psychiatrist Ed.D. once said that schizophrenia literally cannot be understood without understanding despair. And to get that, we have to talk about delusions. These are fixed, false beliefs that are completely unshakable, even when the person is looking right at undeniable contradictory evidence. The most frequent kind are persecutory delusions, where someone is absolutely convinced that entities are actively plotting to harm them. Add to that hallucinations, experiencing things without any actual physical stimulus. These are usually auditory, like distinct, often derogatory voices coming from inside or outside the skull. When you put those together, these positive symptoms create an intensely frightening, alternate reality for the person experiencing them. And this fracturing doesn't just stop at what a person perceives, it bleeds right into how they communicate. Imagine trying to explain something important, but your logical connections just completely unravel. Your sentences simply don't follow one another, making even basic communication incredibly frustrating. This is known as tangential speech. This whole category also includes disorganized behavior, which can be anything from wearing highly inappropriate clothing for the weather to falling into completely unresponsive, rigid catatonic states.
Now, while hallucinations and delusions are highly visible, there's a quieter, often more devastating side to this: the negative symptoms. We're talking about a profound loss of normal human functions, things like flat affect, which is a massive reduction in emotional expression, anhedonia, meaning the inability to feel pleasure, and a severe amotivation that basically paralyzes a person's inner drive to initiate even the most basic daily tasks.
So, by breaking these incredibly complex behavior shifts down into positive, disorganized, and negative categories, we can actually spot the psychological warning signs a lot earlier. Think about it. When a young adult who's just entering the workforce starts withdrawing or showing deep amotivation, it's so easy to just write it off as standard life stress or growing pains, right? But solid mental health education empowers us to accurately identify true psychiatric emergencies, rather than just making assumptions. Section 2. The brain's altered architecture, neurobiology and cognition. Let's pivot to the physical reality of what's happening inside the skull, which completely removes any notion of blame from the individual. The researcher Nancy Andreasen hit the nail on the head when she said that the human brain is a complex landscape, and schizophrenia alters its very architecture. We are dealing with a physical condition of the brain's wiring here, not a lack of willpower. The disorder fundamentally changes how the brain operates and processes information. And these physical changes lead to massive cognitive hurdles. Specifically, they attack working memory, that's your ability to hold on to and juggle small amounts of information over a short period, and processing speed, which is exactly how quickly you can take in details and react to them. These persistent drops in memory and speed severely disrupt a person's ability to keep up with rapid conversations or organize simple multi-step tasks at home or at work. And because these limitations often pop up before the full onset of the illness, they actually point to an inherited genetic vulnerability. So why does this happen? Well, advanced brain imaging shows us that microscopic breakdowns in the brain's white matter, its actual physical wiring, are the true culprits here. Severe structural abnormalities in specific pathways, like the left uncinate fasciculus and the left cingulate bundle, literally sever the connections required for declarative memory. It's a profound physical connectivity breakdown right inside the brain.
Section 3. Triggers, genetics, and environment.
To figure out how these physical changes get kickstarted, we have to look at the intersection of genetics and our environment. There isn't just one single schizophrenia gene. Instead, I love this quote from Francis Collins: "Genetics loads the gun, but the environment pulls the trigger."
It perfectly captures how inherited vulnerabilities, which are combinations of many different genetic variants, just lay dormant until external factors activate them.
So, what exactly pulls that trigger? Well, the risks can actually start way before birth with maternal infections, gestational malnutrition, or even advanced paternal age. But if we look at adolescence and young adulthood, cannabis use is a major environmental factor. For a vulnerable teen who's maybe just trying to self-soothe some general life anxiety, regular cannabis consumption can act as a potent catalyst that triggers a full-blown psychotic crisis.
Section 4. The Early Diagnosis Debate. Clinical High Risk. This brings us to a really hot debate in modern psychiatry. How early is too early to intervene when someone shows only mild symptoms? The Diagnostic and Statistical Manual of Mental Disorders recently added attenuated psychotic syndrome as a condition requiring further study. Basically, this describes individuals showing milder, subthreshold symptoms of psychosis. Now, tracking shows that 35% of youth with these subthreshold symptoms will eventually transition to full psychosis, but applying this diagnostic label right off the bat is extremely controversial.
We really have to weigh both sides of this impartially. On one hand, early identification is a huge plus. It allows for preventative interventions like intensive family counseling and omega-3 fatty acid supplementation that might actually halt a psychotic transition altogether. But on the flip side, we face the devastating potential of diagnostic inflation, high false positive rates, and some extreme social stigma. We run the very real risk of over-medicalizing what might just be temporary developmental or life stress.
It's a massive tightrope walk for clinicians every single day. Robert Rosenthal put it perfectly when he said, "The label we give to a child can become a boundary that limits their entire future." A premature diagnosis of a high-risk syndrome could absolutely crush a young person's self-esteem or needlessly terrify them into withdrawing from their life and their goals out of sheer fear.
Section 5. Treatment, Recovery, and Hope. A holistic approach. Okay, let's look at the final piece of the puzzle, how modern medicine and therapy step in to successfully slow down gray matter loss and restore functional capacity. The first line of defense is almost always pharmacological, but there are major trade-offs between two generations of medications. First-generation typical antipsychotics are great at blocking D2 dopamine receptors to reduce hallucinations, but they come with severe involuntary motor side effects. Second-generation atypical antipsychotics have a much lower motor risk, but they frequently trigger a metabolic syndrome and rapid weight gain. But here is the absolutely crucial takeaway. While both generations can successfully manage those terrifying hallucinations, neither one can consistently fix the underlying cognitive deficits that drive long-term disability.
And that is exactly why a successful treatment model has to be a comprehensive three-step process. Step 1 is a strong pharmacological defense, but Step 2 must be cognitive remediation therapy. This is where patients engage in structured computer-based cognitive exercises to literally rebuild their working memory. And finally, Step 3 requires dedicated social and occupational rehabilitation. By combining the medical strategies with those structured cognitive exercises, individuals can physically protect their brains from gray matter loss and rebuild the mental stamina they need for true functional independence.
Because at the end of the day, comprehensive support isn't just about putting a Band-Aid on symptoms. As Courtney Harding says, true healing requires restoring a person's connection to the world. Treating the cognitive and social deficits is every bit as vital as managing the hallucinations. It's about bringing the individual back into their community. We've got the biology down, we understand the triggers, and we know the holistic treatments actually work. But here's the real question I want to leave you with. Are we as a society willing to tear down the cultural stigma to actually provide that proactive, empathetic care? The next time you see someone struggling, will you just see a label, or will you see a human brain fighting to rebuild its own architecture? Thank you so much for joining this explainer. Keep questioning and keep learning.